Very good morning to all of you and those who have joined online as well. And before talking about the CME program organized by the KSM Weekly, I would like to announce regarding the workshop that we hope to conduct next week collaboratively with the College of Internal Medicine. Actually, I mean, we were very much looking forward to this, and in fact, they have organized on 18th, that is last Tuesday, but due to unavoidable circumstances that we could not go ahead with that. So, but we will be organizing that on 25th, which is the hybrid one as well. So we would like to ask all of you to cooperate and participate as much as possible. Further, that we are, after lack of many years, I suppose, the KSM is organizing a social event as well on 4th of February, a sing-along with Ms. Anasli Madhavana. So on 4th of February at Earls Region at 7 p.m. So it's a ticketed event, but it is very reasonable. We are only trying to get the cost covered. So I think it will be going to be an exciting event. We have one or two past experience of this kind of thing. So it's a very enjoyable thing, and it's going to be very lively as well. So again, I would like to urge all of you to join for that event as well. Coming back to the important event today, a lecture by our consultant rheumatologist and the rehabilitation physician, Dr. Indika Tennakoon. She graduated from the medical faculty in 2006, Colombo, and completed her MD in 2014 from PJAM, University of Colombo. She is specializing in training in rheumatology and rehabilitation with the overseas training at Manchester Royal Infirmary, UK. And she obtained her MRCP from Royal College of London as well. And currently, she is working as the consultant at Rehabilitation Hospital, Digana. So I would like to invite Dr. Indika to proceed with the lecture. Thank you.
Thank you, sir. Good morning, everyone. So we'll talk about shoulder today. This is because most of the time, what I have seen is when the patient presents with shoulder pain, everybody tends to diagnose it as frozen shoulder. What I want to tell you is that it is not the same all the time. So let's go through it. And this is the layout. Just talk about a few things and in introduction. And we'll refresh our memory about the anatomy and physiology. And then let's see how to analyze shoulder pain. And I'll talk about a few common conditions. And most importantly, a few things about posture correction and ergonomics. So this is a very common problem. This is because mainly the shoulder is the most mobile joint in our body, and it has the highest range of motion to complete all our activities of daily living. So because of the same reason, the shoulder is prone to more pathologies and diseases. And at the same time, because it is we need the movements to do all our most of our work, it is quite disabling, and it is the recovery is very slow, as you all know. This is a soft tissue problem. The recovery is slow, and this can be ongoing. So this is a chronic problem which is disabling. Because of that, we have to know what it is. Incidence wise, it is about 14.7% per 100 per year, and lifetime prevalence is about 70%. And there is a recurrence rate as well. I hope you also have come across many patients, and maybe you yourself have suffered from some degree of shoulder problem in your life. So before you're bored with my talking, we'll just go through a video, and I thank for allowing me to abstract from the internet. And let's see. So I think that's enough because I'm going to talk more about the musculoskeletal involvement. The rest is about neurology and the vessels. Of course, it is important. So this is the joint. So it has three bones and three joints, and there's another fourth joint, which is a scapulothoracic joint, as you've heard. And I hope you will remember the applied anatomy just to correlate with the diseases. You can see the range of motion in the different at the different joints here. So the most the vast majority of the movements occur in the glenohumeral joint, but the other joints are also mobile only up to a certain extent. And if we look at how it works, the movement, and so this is the deltoid, and the front part, what it does is flexion and some degree of internal rotation. Um, that is the internal rotation or the medial rotation. And posterior fibers, what it does is extension, as it's shown, and at the same time, some degree of external rotation with the help of other muscles. And the medial part, the middle part between the anterior and posterior parts, it causes abduction with the supraspinatus tendinitis tendon with the aid of the supraspinatus muscle. So this is deltoid, and I hope you will remember the supraspinatus because this has pathologies occurring at the point where it inserts and just before the insertion. So what it does is abduction with the help of deltoid. And I hope you will remember that initially we were told that supraspinatus acts only in the first initiation of the abduction, which is not actually the fact. It acts throughout up to some degree. Of course, it initiates, but it acts throughout the abduction. So the infraspinatus, again, it originates from the infrascapular fossa and then attaches to the greater tubercle just below the supraspinatus attachment. So what it does is external rotation. And the subscapularis is origin is at the subscapular fossa and attaches to the anterior shoulder to the lesser tubercle. And what it does is internal rotation with the help of deltoid as well as the pectoralis major. And pectoralis major, interestingly, there are like combination, different actions which are carried out by the different portions. The first portion, the clavicular head, what it does is extension, flexion, and then the sternocostal part, what it does is mainly the extension. However, together it will do adduction of the shoulder and some degree of internal rotation. So the extension done is actually up to the anatomical position from the flexed position, not beyond that, not posterior extension. So all together, both parts, what it does is adduction and some degree of internal rotation. So the teres major and minor again helps in some of the movements. But remember, teres major is mainly attaching to the shaft of the humerus, so it is not actually a part of the common rotator cuff tendon. But teres minor is a part of the common rotator cuff tendon. And latissimus dorsi is also important because it also helps in some of the functions. And I would like you to think about the importance of trapezius as well, even though it is not directly attached there. The first part, the upper part, actually what it does is elevates the shoulder when the head is fixed. But if the head is, if the shoulders are fixed, what it does is extend the neck back. And the lateral flexion is brought about when only one side of the superior fibers are working. When the other side is not working, only stretching. And the lower part, what it causes is abduction of the shoulder when it is going beyond 90 degrees. Because up to the 90 degrees, the scapula is normally fixed, and beyond the 90 degrees abduction, only the scapula is moving, and that is brought about by the lower fibers. So this is important when we talk about the pathologies. So so with those in mind, let's go through a possible phenomena, the clinical presentation. This is a 45-year-old lady with right shoulder pain. It's commonly seen in our clinics. I normally see out of 25, 30 new cases, at least 3, 4, maybe 5 every clinic visit. I hope it's the same as other rheumatology clinics as well. And so this for about 3 months, maybe 6 months, or even sometimes late presentation. Initially, there's more continuous moderate pain and stiffness. Later, the stiffness is more. And sometimes they complain of sharp pain with the movements, especially some jerky movements. It is very sharp, and some people complain that they even like become faintish because of the severe pain. And some activities bring about pain around the elbow and wrist as well. This is because of the change in the biomechanics of the shoulder and the arm. And it is actually worse at night. If accidentally you sleep on that side or turn to that side, it is worse. And there's difficulty in reaching, especially the higher racks or overhead activities, and sometimes dressing, putting the hooks and the buckles and the zippers, and other activities as well. And there is always associated neck and upper back pain. So what could this be? On examination, what we see is in this lady, both passive and active movements are restricted. So when we say both active and passive movements are restricted, that means it is either the capsule or within the joint. So it is intracapsular. But if it is only the active movements are restricted and painful, and we can do the movements with little pain. So that means passive movements are normal. That is mainly extracapsular. So that is either the muscle or the tendons or some other pathology. So this could be commonly shoulder capsulitis, frozen shoulder, as you all know. But there are other pathologies like rotator cuff tendinitis and with some impingement. And bicipital tendinitis can come like this. Maybe there are little changes in the clinical presentation. And glenohumeral arthritis. So this can be either early inflammatory arthritis like rheumatoid arthritis or osteoarthritis, maybe secondary to some previous trauma or some other injury. And another pathology is AC joint, the acromioclavicular joint arthritis, which can be missed unless you examine. And polymyalgia rheumatica, but it's usually bilateral, and age is not actually compatible. It's more in elderly. And other common causes like spasms, poor posture due to occupation or the poor posture maintenance, or cervical spondylosis, radiculopathy, and other things like brachial neuritis, cervical rip, which can come. I'm talking more about the musculoskeletal side of the pathologies. So what is shoulder capsulitis? So this is mainly an inflammation of the shoulder capsule, which is leading to a thickened and like capsule with thickening and adhesions and less synovial fluid. So in the picture, you can see that the capsule is more lax initially, and then with the inflammation, it becomes thick and the movements are restricted and it's stiff. And there's pain initially, and then stiffness, reduced range of movements. So this is shoulder capsulitis or the frozen shoulder. So just to complete, the incidence is about 3 to 5%, and it is common in diabetes and hypothyroidism. We always ask whether the patient is diabetic if we find out it is more likely frozen shoulder. Age is between 40 to 60, but other age groups can get it, and it can be bilateral. And the MRI scan here shows the thickening of the axillary recess here. And so there are 3 stages. So understanding this is important because then only we can tell the patient what to do and how to manage this. So there are 3 stages, which is it can take 1 to 3 years. So initially there is more pain. We call it freezing stage. There's more inflammation, so there's more pain. But when time goes on, it becomes more frozen, and the stiffness becomes more than pain, and the movements become restricted. And later, there is a phenomenon called thawing. It is improving stiffness and the range of movements in the latter part of the disease. However, if we don't do the correct treatment, the patient can end up having a stiff, limited shoulder. obviously disabling. So if we examine, so both the active and passive restriction is there with pain. So this patient is trying to abduct his left arm, and so you can see how the spine curves and the muscles of the back also come into play, because he can't do it because the glenohumeral joint is not working. And again, the external rotation, this movement, trying to put the hand back on the back of the head, and again trying to reach the back of the back, low back, and both. So that is internal rotation. So all are restricted. We can try these simple 3 movements to see um, how and what has happened, and then do it passively as well to see whether it's both active and passive restriction. And so what happens when the biomechanics changes? So the glenohumeral joint is stiff, but we have to do our activities of daily living. So what happens is the other muscles try to adapt to different movements to get the things done. And especially the back muscles, I hope you can remember the video also. So there is the scapular movement starts when the shoulder is at the 90 degrees abduction. But here, because the glenohumeral joint is fixed, the scapula, there's early mobilization of the scapula. So because of that, all the back muscles, the trapezius and others in the medial side, the rhomboids, they are always overworked. Because of that, they have a lot of pain in the neck and the back as well. And this is the same reason that some people complain of pain in the forearm and sometimes around the wrist as well when they try to do some work. That is again because of the change of the biomechanics. When they're trying to do something, other muscles come into play and try to do it somehow when the glenohumeral joint is stiff. So the most important thing here, actually, I have not included the patient education. We have to explain what this is and explain the long process and explain and tell them to do the exercises at home regularly throughout this period, because it is going to improve. But unless you do the exercises of the range of motion exercises, it will not improve and it will keep, stiff joint will be there. So because of that, we have to educate the patient, and the pain relief and anti-inflammatory will help. Anti-inflammatory will improve the inflammation, but the pain relief is important because unless we relieve the pain, the patient will not move the joint and they will not be doing the exercise. So sometimes we might have to give a bit of a long-term pain killers, pain treatment, unless there are contraindications. Muscle relaxants are important because, again, there's a lot of muscle stiffness here, muscle spasms here, not the stiffness, spasms. So muscle relaxants will help to relax the muscles and less pain. And physiotherapy is very important. So initially what we have to do is we have to stretch the capsule. So before doing the strengthening exercises, initially you have to stretch the capsule, and the therapist will do it manually. At the same time, we have to do the exercises ourselves at home as well. So stretching the capsule and doing the range of motion exercises, and then later on strengthening exercises. Steroid injection will help. Initially, it will help in reducing inflammation. At the same time, it will help in reducing pain. So sometimes, because the pain is relieved, patient gets the whole range sometimes. So it is the glenohumeral joint injection, anterior posterior approach that we are doing. Hydrodilatation was carried out some time back. I don't think it is practiced nowadays. There are surgical options as well. So if nothing is working, we can get the surgical colleague's opinion. So next one is, let's think about a different scenario. So the same lady presenting with pain, but there may not be that much stiffness, and the sharp movement is actually coming from the capsule. So it might not be there, but some movements can cause it, and it is more or less a similar presentation. Pain with movements, with reaching, dressing, sometimes carrying bags and all. And but when we examine, the active range and resisted movements are painful. Sometimes only one movement, sometimes even other movements to the different movements. But um, uh, active range and resisted movements are painful and restricted, but the passive range is normal with less pain. So in this scenario, it is less likely to be shoulder capsulitis. It is more likely to be rotator cuff tendinitis. So this is a different pathology to shoulder capsulitis. So let's go through a bit of it. So we know there are 4 muscles in the rotator cuff: supraspinatus, infraspinatus, teres minor, and subscapularis. So this the importance of these muscles are they insert into the anterior and posterior shoulder, and it makes a common rotator cuff tendon which is involved in the shoulder movements. The incidence of the tendinitis is about 0.3 to 5.5%, and there are theories about some extrinsic compressions like the acromion having different configurations and pressing on the supraspinatus tendon. And there are some theories about intrinsic tendon factors such as differences in the collagen and the other structures, so can cause early degenerative changes. So the risk factors are the age and some related work, repetitive activity such as painters. Sometimes the sports with overhead activities such as tennis, badminton can cause it. And so the phenomena about common rotator cuff tendon is here. So it is the inflammation of the rotator cuff tendon, and there is pain diffuse, but it can be anterior sometimes or lateral. It can refer down up to the elbow. Sometimes it refers to the lateral arm where the deltoid is inserted. So the patient might come and say that the pain is in the around the deltoid insertion, but the pathology is mainly in the shoulder. And they will have difficulty in lifting, pushing, mostly overhead movements, and hand behind back movements as well. So the active movements are painful and restricted, but when we examine the passive movements are less painful and we can do it. So what is shoulder impingement? It is a phenomena where the rotator cuff tendon, mainly the supraspinatus tendon, and the subacromial subdeltoid bursa, which is between the supraspinatus and the deltoid, is inflamed when mainly the shoulder is abducted. So this happens with repetitive overhead activities. So we call it supraspinatus tendinitis or SST bursitis. So this more or less go hand in hand, and both the findings are there when we do the ultrasound if we think this is the cause. So there are some special tests to diagnose the rotator cuff tendinitis with the impingement. So one is a painful arc. The painful arc is mainly when we do the passive movement or even active movements. Initially, there may be no pain, but after about 60 degrees abduction, there is mid-range pain. And beyond 120, again, the pain improves and maybe there won't be pain. But practically, my experience is I normally won't be able to do this maneuver beyond maybe 90 degrees because of the pain. So we won't be able to elicit the upper range where there's no pain. And the Hawkins test is again as illustrated in the picture. We do the internal rotation with the arm abducted and elbow flexed 90 degrees, and it brings pain because it is pressing on the coracoacromial arch mainly. The empty can test is as if we are emptying a can like that. We keep the arm to a side with flexion and abduction and apply pressure where the patient resists, and then again the pain is reproduced. Supraspinatus test is mainly resisting the external rotation, seeing the supraspinatus is painful. The pain is reproduced with the movement. So how are we going to diagnose? Again, if this is a clinical diagnosis, we have to examine and do the tests and try to diagnose. Ultrasound helps. As you can see, there is the supraspinatus tendon tear is there, the hypoechoic area. This is supraspinatus tendon. So we refer if there is a tear. Normally, what happens is the patient can't keep the arm abducted like that. They tend to drop the arm. So that is a suspicion clinically if there is a tear. So we send for scan and then we can see that the tear can be partial or complete, and bursal inflammation is shown, and the tendon inflammation fluid around tendons are shown in the ultrasound scan. X-rays will show the calcifications as in this picture. The supraspinatus tendon insertion, there is calcification. And the acromial-humeral interval is something that we can look at, because there should be enough space between the humerus and the acromion, and it is restricted in these patients because of the long-standing rotator cuff tendinitis, and it degenerates, so the space is less, and the head of the humerus and the acromion comes closer. Obviously, MRI will be more informative. So the treatment-wise, again, we have to relieve the pain and relieve the inflammation. So we can use non-steroidal anti-inflammatory, and again physiotherapy with other wave treatments and the exercises. This should go gradually without causing too much pain and the patient refusing to do the exercises. And we can do the steroid injection that is mainly to the subacromial subdeltoid bursa, that is not to the glenohumeral joint. And the other thing is sorry, surgical repair. And if there's a acromial abnormality, we can ask for the acromial depression. So the next one is the bicipital tendinitis. So as the rotator cuff tendinitis, the bicipital tendon can get inflamed. So this is inflammation of the bicipital tendon, which happens in the bicipital groove. This is a long head of biceps, and this is again chronic, acute and chronic overuse. The cause is acute and chronic overuse, and again patient will present with painful shoulder, anterior shoulder, or maybe the diffuse pain, and there will be pain on elbow flexion and carrying heavy bags and all. And there's tenderness when we palpate the bicipital groove. There's maximum tenderness there, and the speed test is the resisted movement of flexion. Again reproduces pain in the same area, and this ultrasound scan will be confirmatory, so you can see the tendon there, and then there's fluid around the tendon. This is in the bicipital groove. Below is the intensity is the bone, and above is the deltoid muscle. So again, it is the same. We have to relieve the pain and give some anti-inflammatory, and we have to send for the therapy, and we have to aim the therapy to the point, to the diagnosed pathology, the point where the diagnosed pathology is. And steroid injection, we can try to the tendon sheath, not to the tendon, because injecting into the tendon will cause tendon tears. It's more prone to tendon tears, and it's injecting around the tendon in the tendon sheath. Activity modification should be done if it is like coming up again and again. So now, after talking about all these pathologies, I would like to tell you that there is this shoulder rehabilitation program. That means the set of exercises that we should teach patient. Tell them to do it regularly, long term, to recover, because it is a slow process, slow recovery, and it can come again, and it will be disabling unless they do it. And we won't be able to help them if it is very stiff and too stiff, and we can't do any therapy as well because it is too late. So I would like to give two references, and this is Arthritis Research UK website leaflet, and then the other one is American Association of Orthopedics, the Orthopedic Association, and so the very illustrative leaflets. Initially, we have to do some pendular exercises according to that, without causing too much pain, and then later on we can do some active exercises as well. So please refer to these, and maybe we can tell the patients, or have pictures demonstrated in our clinic rooms, so we can tell them to look at it and then explain what to do. So the next one is AC joint separation. So the pain in the AC joint, unless we examine, we won't be able to know. The patient will come with the shoulder pain. So there is maximum tenderness in the AC joint, and it is at this point. When we pull the arm down, there can be, if there's separation, there will be a bump elevation coming up. And the pain is worse when the arm is crossed to touch the opposite shoulder across the chest. So this is X-ray wise, this is grade 1 separation, and this is grade 3 separation. And the glenohumeral arthritis is another cause of shoulder pain. So when we say glenohumeral arthritis, there are two types, either inflammatory or degenerative. When we say inflammatory, the inflammatory pain I hope you all know, inflammatory pain is worse in the morning, and stiffness is worse in the morning, and it improves with activity. It's worse in the morning means it's worse after resting. And in contrast to that, degenerative pain or the osteoarthritic pain is worse after activity, and it improves with resting. So there's inflammatory pain and stiffness, and again, this is intracapsular. That means it is within the joint. So the pain, the passive and active movements will be painful. And we have to look for the other features of inflammatory arthritis, because diagnosing inflammatory arthritis is a pattern recognition where we look at what other joints involved, what other systems are involved. But remember, this can be the earliest presentation with monoarthritis. So there will be joint line tenderness, and there will be other joint involvement, and there will be inflammatory marker elevation. But sometimes we have seen early inflammatory arthritis, the inflammatory markers can be normal. And then we have to use synovitis if there's any doubt in diagnosing. This showing a lot of synovial thickening in the grayscale. And the next picture is a late disease where there's bone erosions, where the bone line is cracked and it is depressed. And if you do the power Doppler, it shows a lot of arteries and increased blood flow. So the evidence of synovitis and increased blood flow, this means evidence of synovitis in the ultrasound scans is very useful if we are stuck with like one joint involvement and we are not sure whether it's inflammatory. If there are no other joints, so you might have to ask for ultrasound to confirm. The osteoarthritis, that is mechanical pain with restricted movements. We have to look for the features of osteoarthritis. And the X-ray, there will be narrowing, because the osteoarthritis means there is a degeneration of the cartilage. So the space will be narrowed and there will be osteophytes formation. So so we can give intraarticular injections to inflammatory arthritis as well as osteoarthritis. It will improve the inflammation and the pain. So on all the shoulder injections are not the same. So there are different injections. So the first one is acromioclavicular joint here, and then the subacromial bursa, that means for the rotator cuff or the supraspinatus tendinitis. And this is the bicipital tendon injection, but this origin is actually wrong. It is not the correct process. It's long head of biceps, which originates from the superior glenoid, and the joint that is a glenohumeral joint injection. So there are different types of injections for different pathologies. However, I would like to talk a little more, a few things about something else as well. So, what do you think the commonest cause of neck and shoulder pain? Because always when the patient presents, it's not only the shoulder. Of course, some patients will say mainly it's shoulder, but most of the time it is neck and the shoulder. I happen to see even younger ones like children with a lot of neck and shoulder pain these days. So, the commonest cause is actually the neck muscle tension or the strain and of the ligament strain due to the poor posture. So most of us are like this now. Most of the time, the children are also like this because of the online teaching and learning processes. So what is text neck? Any idea? So the text neck, I think everyone is now having text neck. So this is text neck. We are texting and then we are keeping the head down. So this long-standing, long hours of the text neck will cause problems because of the abnormal posture. So I think it's time to listen to another interesting video. So I thank for allowing me to extract it. So as you can see, because we all are now in front of computers and using most of phones most of the time. And I think phones are worse because in a computer we can sit and adjust, but phones we always like is looking down. And so this is a workstation ergonomics to prevent the neck pain. As you can see, the heights should be as described. The eye level should be at the upper 1/3 of the screen, and the elbows flex to about 90 degrees and relax on the table, and the hips and the knees are flexed at least 90-90, that is 90-90 sitting, right? And the foot should be on the floor. If there is if it is not enough, we have to put another either a stool or a log and then sit, so we can see that. And actually speaking, our tables and chairs are not standard to fulfill these needs. So we always have to see when we buy tables and chairs, at least for our children. So you can see how they will posture. So please tell them how to sit and how to do their work, because they'll be most of the time writing or sitting at a desk. And so even sleeping, what we have to do is not a big pillow, not a thick pillow. It's a thin pillow to prevent the normal cervical curvatures, to maintain the normal curvatures even on sleeping. And what about lifting? Just to complete, and we have to bend with the knees, not the back mainly, and then lift up. And interestingly, backpacks are again these days are very heavy. So again, this is a thing to look at, because we tend to lean forward with the backpack, heavy backpack, but correct posture is very important. So with that, I think I'm going to finish. So again, there is a neck pain, the rehabilitation leaflets are there. Again, the Arthritis Research UK, West Arthritis. You can go through it and then get some information and maybe apply practically, at least to yourself and your colleagues and relatives and children. Thank you.
Thank you very much, Indika. Do you have any questions? Probably you must have, because all are texting. Texting. All decisions cell phone. While eating, while driving. Yes.
It is to a like a tendon sheet or the leader of the tendon. We should avoid the strenuous exercise long. That's what I feel. But generally, we tell them not to do exercises for 48 hours. Like at least for trigger finger and then bicycle tendon, so you continuous. I tell them even the next week, the coming week, they should be doing like that. Can I ask you a question? Do you PRP in relation to the yeah, I just wanted to what your experience. Because we don't do it in the database, but have facilities too, but there's not much of evidence. No. Yeah. And use the reaction. Yes. Yeah. And everyone is a bit more pain. Sometimes we tend to tell the patients that after the injections, sometimes they can get worse pain or that, so we can rally use particles. But then, of course, without the next, but it could be a bad experience for patient. Ah, okay. Yeah. Okay. But once I injected the Radican numbers are with the transient came for a doctor, came out again, but then gave the information until now it's fine. I'm encouraging to diabetic and endocrine unit because we mostly come across things very common scenario. Usually, for the patient who can sit up, I think after listening to the lecture, it's always advisable to send the patient to a rheumatologist session and then put the physiotherapy rather than straight away.
Thank you, Dr. Indika Tennakoon, for that very illustrative lecture and touching up with the anatomy and the new thing, elaborating the text neck, probably you will have. And just another remind regarding our symposium, which is on 25th, organized by the Internal Medicine, College of Internal Medicine and the Cancer Society of Medicine, which is very good symposium, mainly touch upon the non-communicable diseases, which is on 25th, and only 50 participants are allowed. So I cordially invite Dr. Rutini Bulpitia, the consultant intensivist, National Hospital Kandy, to give away the certificate to Dr. Indika. Thank you very much once again. Thank you all the participants, physical and online participants, and thank you very much, sir, for your active participation for the discussion. Thank you. Refreshments will be provided. Okay.
Okay නේද? Okay. නෑ not for rheumatologist. මේක මං අදලා ගන්නද? එපාද?
අදලා ගන්න තියෙනවා.
එපා නේ ඒක සාමාන්‍ය මොකද්ද කරන්නේ?
නෑ මම
චෙක් කරලා වෙනවා කරලා.
ඕකේ කරන්න ඉතින්.
You are currently the only person in this conference.